the latest updates of the pathophysiology as well as principle of treatment of severe or refractory primary nocturnal enuresis. I think a lot actually has happened over the last 20 years, and the current concept of what primary nocturnal enuresis is, I have to say, is pretty different from what we used to know or before year 2000.
Flip it on the full screen slideshow.
Okay.
Yeah.
Okay.
That's nice. Thank you.
Okay. So the current concept of primary nocturnal enuresis is most importantly that it is not a homogeneous unity. Rather, it is a very wide spectrum with heterogeneous underlying pathophysiologies. It is due largely to a mismatch between the nocturnal urine volume production and the nocturnal bladder volume. And there is a very important role of underlying bladder dysfunction as well as bladder bowel dysfunction, even in the so-called monosymptomatic primary nocturnal enuresis when the child didn't complain of major urinary symptoms during the daytime. And the severe or refractory nocturnal enuresis actually are light sleeper with a lot of sleep disturbances instead of being deep sleeper. I'll come back to this point later on. And there is actually a very dynamic and interactive bladder-brain dialogue existing in this group of children with very severe nocturnal enuresis that are refractory to treatment. And most importantly, the disease is curable, particularly if we can, if we actually can find out the underlying pathophysiologies, especially bladder bowel dysfunction, and then really design our therapy targeting at the underlying problem. So what is more important for us to understand is, apart from the fact that primary nocturnal enuresis is not a homogeneous unified entity, but rather a wide spectrum of entities, is that not all forms of nocturnal enuresis will disappear and subside with increasing age. Well, our research showed that only actually the mild forms with mild symptoms do. And the severe forms with very severe bedwetting, say 5-6 times a week, are actually very likely to persist into adulthood. And this should actually form the target group of early treatment. And we have actually published this in a few articles in the early year 2000. Now, when we look at the prevalence of nocturnal enuresis in children and adolescents, yes, indeed, or we can see that the prevalence does decrease with increasing age. Now, this is a study that we did some 20 years ago, and involving a very large number, over 21,000 survey of school children. And yes, if we look at the overall prevalence, indeed, the prevalence at age 5 is around 15 to 16%, whereas when it comes to age 10 or to 12, it comes down to 2 to 3%. However, we can also see that once after age 10 to 12, the actual overall prevalence doesn't decrease significantly afterwards. Now, what's more interesting is if we break down the overall prevalence into different symptom groups. All right, the green representing the mild symptoms, those wetting less than 3 nights per week, whereas the red representing those with very severe symptoms or wetting every night, or if not more than once every night, and the yellow represents somewhere in between. Then we can actually see very, very clearly that the reduction or decrease in prevalence actually occur mainly in the mild symptom group, in the green and the yellow, whereas those with very severe symptoms, actually the prevalence doesn't really change at all. Now, this is actually echoed by another study that we focus now in the adult age group of patients with persistent nocturnal enuresis, who had bedwetting since childhood, but then we focus on the group age 16 to 40. Now, again, all right, to our astonishment, what we have found is that once after the age 16 to 20, the actual prevalence doesn't decrease with increasing age. And this applies both to males and females, right? The overall prevalence stay at around 2 to 2.5%. And more importantly, if we look at this severity of symptoms in this adult group of anuretic patients, then we can see that a much higher percentage, actually over a quarter, or 26% of these adult anuretic patients are having very severe symptoms, and we include those with moderate to severe symptoms, or wetting 3 to 6 nights, then actually the two would comprise more than half of these adult patients with persistent enuresis. So the message that we need to bring across is that persistent nocturnal enuresis into adolescence and adulthood actually tends to persist unresolved, or till a very advanced age, till 40 or even 50, and it is nearly always associated with significant underlying bladder dysfunctions. So this is another very, very important message. Now, so what actually is causing nocturnal enuresis? As I say, it is a very wide spectrum of heterogeneous group of disorders, but it is largely due to a mismatch between the urine output volume at night, which is in excess of the bladder capacity at night, or the nocturnal bladder capacity, and together, if there is also a failure to awake in response to bladder fullness, all right, then nocturnal enuresis or bedwetting will ensue. Now, this is, of course, one very famous study from the Aarhus group from Denmark in the late 80s, all right, showing that in a small subgroup of anuretic patients, that there is a derangement of the diurnal variation of antidiuretic hormone secretion at night, in the way that as compared to the normal children, where we can see that at night there was an increase in secretion of antidiuretic hormone, leading to a concentration of urine and therefore the reduction or decrease of urine production volume. In this anuretic group, or at night, there is not this comparable increase in antidiuretic hormone secretion, and therefore there is a lack of concentration of urine, leading to excess production of dilute urine, just like during the daytime. And this, of course, is associated with the bedwetting or enuresis. Now, however, as we have known now, this only constitutes a small fraction of the bedwetters or the enuretic children, particularly the severe enuresis. But even in this group of children with bedwetting who had nocturnal polyuria, all right, the lack of increase in secretion of antidiuretic hormone at night, or lack of urine concentration at night, only is one of the many factors of nocturnal polyuria. We now know that, all right, there are also cases with solute diuresis, with increased renal excretion of sodium and other solutes at night, or there are a combination of both water and solute diuresis, as well as other hemodynamic factors or renal resistance to vasopressin and so on. So this is very heterogeneous, all right? That is the message. And then our landmark paper in late 90s, which we published in the Journal of Urology, is that actually the bladder is the key, right? Particularly a reduction of the functional bladder capacity at night, or the nocturnal bladder capacity, all right, which only happen at night, all right, is or small bladder volume at night, is actually very, very highly prevalent, all right, in those children with severe or adults with severe nocturnal enuresis, all right. And this also can be divided into two large subgroups. The first subgroup, all right, are those who have actually normal daytime urodynamics. So, and they have no urinary symptoms during the daytime. Even if you investigate them with urodynamics, their bladder function are largely normal. But once they fall asleep at night, then the bladder become unstable, and there are appearance of significant detrusor overactivity in association with reduction in the bladder volume at night or after sleep. So this is one important subgroup. The other subgroup, of course, are those actually whose urodynamics, even during the daytime, are abnormal, but somehow they can hide their bladder symptoms. Either they don't drink or they go to the toilet more frequently. So if you just ask them whether they are wet during the daytime, they are not. They are dry. So they are, by definition, monosymptomatic, but actually they do have abnormal urodynamics. Now, we actually have done another study using ultrasound measured bladder indexes, and we actually can have showed a very significant correlation between a thickened bladder wall together with a contracted bladder volume, or with a thick bladder wall or thick muscle with the response to treatment. What we have found is that if there is a significant reduction of the bladder wall thickness index below 70, which indicates that the bladder is both small in volume and thick wall, then the response to treatment that you can see on the right side, the two columns are much worse than those who have normal bladder volume and normal bladder wall thickness. So once again, showing that underlying bladder dysfunction, and as a matter of fact, underlying bladder bowel dysfunction is a very, very important association factors in those with severe enuresis, particularly those refractory to treatment. Now, what about the sleep? We have also done a lot of studies over the last 30 years as to the sleep changes in children with severe nocturnal enuresis in association with their bladder behavior after sleep at night. Again, we have found significant differences in the bladder behavior and sleep changes in this severely enuretic children and adolescents. Unlike the normal children, which is shown on the left side of the slide, that when the bladder fills up during sleep, then the sleep EEG changes from deep sleep to light sleep, and then eventually, as the bladder becomes fuller and fuller, actually the patient will, the child will wake up altogether, and then they actually will go to the toilet and pass urine. However, in sharp contrast, the severe enuretic, we actually do also see that as the bladder fills up, there is actually a change from deep sleep, or the EEG change from deep sleep to light sleep in association with increasing appearance of a detrusor activity. But as the bladder continues to fill up and the bladder becomes more and more active, the child actually remains in this semi-aroused and semi-sleep state, and without further total awakening. Apparently, the threshold to awakening, total awakening, is actually elevated, and they failed to wake up entirely, and then micturition ensue in this light sleep or semi-aroused state, and this constitutes an enuretic episode. Now, we have actually done, again, very extensive studies. This is what we have published in the New England Journal of Medicine some 14 years ago, showing that as compared to normal non-enuretic or dry children, then we compare the sleep architecture and cortical arousal episodes in this enuretic children, then we can see that the upper row, the NE or enuretic children, actually have much more light sleep, particularly sleep stage 1, and they have significantly less deep sleep, particularly stage 4 and also non-rapid eye movement sleep, as compared to normal non-enuretic children. However, their arousal index is significantly increased. So this is a very, very important finding in that, showing that actually these children, in contrast to what we believe traditionally, actually they are not deep sleepers, they are actually light sleepers, but the threshold of awakening is impaired, is elevated, so they actually fail to wake up. So in a quick summary of what we have found with respect to pathophysiologies of severe enuresis or bedwetting, particularly those refractory to treatment, is that in contrast to our traditional belief, children with severe refractory nocturnal enuresis actually have overall light sleep instead of deep sleep. The cortical arousal was closely associated with bladder overactivity, as we have shown by polysomnogram during sleep at night. But despite increased cortical arousal, there was an inability of complete awakening, most probably related to a paradoxical elevation of conscious awakening threshold. And actually, we have done further studies to compare the cognitive performance of the severely enuretic children versus normal control. And actually, not surprising now, we have actually documented that for the severely enuretic, particularly those who are wetting every night and not responding to treatment, the overall cognitive performance, including the intelligence score, the focused attention, short-term memory, retention ability, long-term memory, and also learning speed and reaction are much impaired, significantly impaired comparing to normal control. The good news is after successful treatment, actually these are reversible. So again, quick summary that we actually have found there was a very significant bladder-brain interaction causing sleep arousal disturbances in severe enuretic children. Instead, there was a mismatch with reduced nocturnal bladder volume, sometimes without nocturnal polyuria, which cause an increased brain arousability. And the frequent cortical arousals lead to more light sleep, but there is paradoxically an inability to awaken completely. And the transition from light sleep to complete awakening, as normally elicited by the arousal center, becomes paradoxically suppressed by long-term overstimulation by signals from the bladder in this enuretic children, a phenomenon I call discotheque phenomenon, because it is very similar to when we walk into a very noisy place like in our age, or we call it discotheque, right? That we just hear the noisy music for the first 20 minutes, but then subsequently we do not hear, all right? And this is again due to, all right, the elevation of the cognitive threshold to hearing by the brain after overstimulation by the noise signals. And concomitantly, other central nervous system functions, including cognitive function, actually are likewise impaired in this group of children. Now, we actually have go further, right, to try to document the same relationship between bladder, change in bladder behavior, and also sleep architecture, cortical arousal, and also cognitive function using an animal model. We use large white rat, and then we reduce their bladder to less than 30%, and then we implant electrodes into their brain, and then we actually perform telemetry and also with radio telemeters to actually document the sleep EEG as well as the bladder contraction continuously. What we have found is that, again, very, very significantly, that we actually can reproduce what we have shown and found in the severely enuretic children. And that in this group of rats with reduced bladder volume, that during sleep, their bladder become active, or because of the reduction in volume by surgery very quickly. And then this is associated with the change from deep sleep to light sleep. And then voiding actually occurs in a semi-aroused state. And then the rat will return to deep sleep after voiding. And then the same cycle will repeat itself again. So very similar to what we have documented in human in the severely enuretic children. In this rats with after bladder volume reduction, we actually can show, or in the reduced bladder volume RBV group, that there is a significantly increase in light sleep and compared with the sham group, and also there is a significant decrease deep sleep compared to control, although the arousal index is likewise significantly increased. So we actually can reproduce what we have found in the severely enuretic children in rats after surgical bladder volume reduction. And actually, if we subject these animals to functional MRI, actually we also can see that there are functional changes in the central nervous system in response to just surgical bladder volume reduction. In that, comparing to the sham group on the left, we can see that the reduced bladder volume, or the RBV group, actually had a deactivation of the ventrolateral periaqueductal gray area, as evoked by bladder volume reduction. We can see that there is a lack of stimulation with bladder distension. And actually, we observe this rest, after bladder volume reduction, and we actually see that this rest will continue to feed all the time, and they became very big and very obese. It's actually like a little guinea pig. And also they are cognitively impaired, very irritable, and very aggressive. At one time, one of these rat nearly bit off my finger. So they are very aggressive, and they eat all the time, but they are cognitively impaired, as shown in this water maze task study. As you can see that we subject this rest after reduced bladder volume to water maze, and see how well they can learn to find the platform, so that they will not be drowned. And then we can see that after bladder volume reduction, we can see that it takes much longer for this RBV rat to learn and to find the platform. Okay, so unlike our traditional belief that the bladder is solely under the control of the brain, in that brain dysfunction can lead to bladder dysfunction, what we have found is that with bladder dysfunction, either naturally found in anuretic children or surgically induced in the RBV rest, we actually can also cause brain dysfunction with sleep arousal disturbance and CNS cognitive impairment. So let's have a quick word on what are the management principles of severe nocturnal enuresis. I would like to emphasize that only those with severe symptoms and those with very refractory nocturnal enuresis is worth treatment, because the mild symptoms group actually usually they will actually subside by itself. So the principle of management of this refractory and enuretic children is that, as I alluded to in the beginning, that we must be aware that they are not a single homogeneous unity, but they are a very wide heterogeneous spectrum of disorders with different underlying pathophysiologies. And successful treatment must be based on correction of the mismatch between nocturnal urine volume production and nocturnal bladder volume after sleep at night. And we must, of course, first reduce the urine preload before bedtime by fluid restriction, because of the mismatch. But we always must be mindful of the underlying bladder bowel dysfunction. Many times the symptoms can be very subtle, so that we can even label them as monosymptomatic. And then we must be also very resourceful in treating the associated bladder bowel dysfunction. And many studies by various workers over the last 10 odd years have shown that combination treatment with not only desmopressin, but also anticholinergics plus urotherapy and plus or minus neuromodulation, electrical stimulation, and plus or minus imipramine, in general, is significantly more effective than monotherapy in treating these children with or adolescents with refractory enuresis. This is a study published in the Pediatrics Journal showing that combination treatment with desmopressin as well as an anticholinergic for non-responders to to desmopressin alone actually is much more effective in causing a reduction in symptoms. This is another study published in the British Journal of Urology International, showing that a combination of desmopressin and oxybutynin actually have a much higher rate of full as well as partial responses compared to the placebo group. Yet another study showing desmopressin together with anticholinergic is much more effective than desmopressin alone in treating primary nocturnal enuresis. This is a study showing that electrical stimulation targeting at the underlying bladder bowel dysfunction also showed that there was a significant reduction in symptoms as compared to the placebo group. So, quick summary. All right. Nocturnal enuresis comprises of a diverse spectrum of conditions with a mismatch of nocturnal urine production that is in excess of the nocturnal bladder storage capacity, together with an impairment of conscious awakening response to the sensation of bladder fullness. The patients with severe enuresis do not only suffer from social inconvenience and embarrassment, but also from significant sleep deprivation and other CNS dysfunctions that are often associated with underlying bladder dysfunctions, which warrant special treatment. And most importantly, combination treatment aiming at correction of the underlying bladder dysfunction and reduction of nocturnal urine output to cater for a small functional bladder capacity so as to avoid chronic overstimulation of the central nervous system can lead, thus leading to arousal disturbances, are actually much more effective. And target therapy aimed specifically at underlying pathologies, actually in our experience, can produce a complete cure in the vast majority, I would say over 95% of patients with refractory enuresis. All right, this is all I would like to say. Thank you very much indeed for your attention.